Welcome back to the Dementia Collective, the podcast where we explore powerful stories and fresh ideas shaping the future of dementia care. If you're new here, I'm Andrew Karesa, a caregiver, researcher, and founder of BlueBell Village. I created a space because I've lived the dementia journey firsthand. I know what it's like to feel lost, overwhelmed, and alone. I also know the strength that comes from connection. Each episode, we dive into the people, tools, innovations that are helping caregivers find their footing and their voice. Our mission to make dementia care more personable, more connected, and more grounded in the Indigenous ways of knowing, because every caregiver deserves to feel seen, heard, and supported. Today, we're honored to have Dr. Sharon Anderson join us to talk about her work on supporting caregivers. For all the caregivers listening, this is one episode you won't want to miss. Dr. Sharon Anderson has a Master's of Education in Community Rehabilitation and Disability Studies from the University of Calgary, a Master of Science in Public Health, and a PhD in Family Gerontology in the Department of Human Ecology from the University of Alberta. She has worked with Dr. Jasny Parmer in the caregiver-centered Care Health Workforce Education Program of Applied Research and Innovation in the Health Services Delivery and Family Caregiving in the Department of Family Medicine at the University of Alberta since 2018. Tansei, Dr. Anderson, welcome to the Dementia Collective.
You know, Andy, what you're doing here is so important because caregivers, and what you said in the introduction, caregivers are diverse. When you met one caregiver, you've met one caregiver. The person they're caring for, the condition they're caring for, every single thing about them is going to be different. And that trajectory is going to be different. What happens to them along there. And so we need all kinds of different providers in this, and we need to collaborate. How do we do these warm handoffs? How do we make sure that people are not left navigating, trying to find things on their own?
Yeah, I mean, we'll try and find whatever we can is best, but I see there's two problems often: that the people don't always know where to go, and then the people don't always want to facilitate warm handoffs because maybe it's a competition, which is where I really hope that some of this work that you're working on with reshaping the caregiver strategy can really help address some of these concerns that I see.
Yeah, the thing that we really noticed so first of all, we did the caregiver-centered care education. So educating healthcare providers, community providers, social care providers to support family caregivers. And that's one piece of it, because healthcare providers was really a missing piece when Dr. Parmer started working on this in 2014. But what you could see here in Alberta is many of the services and supports caregivers needed are available in healthcare, in the community. They're just oftentimes providers don't even know. We did a survey with family docs, and navigation was the most difficult thing for them to do. One family doc said that in their PCN, they had gotten they'd hired a person to actually collate all the resources that were available around in their area. And at the end of 6 months, she needed to start doing it all over again. So how do we build that better system to support family caregivers?
100%. And I think that just this little introduction, little start here is really reaffirming that you are a leading voice in, caregiver-centered care in Alberta, and I would argue a much wider lens, Canada-wide. Before we dive into the specific details of the Caregiver Action Plan and some of your work on that, can you talk about how you got into this journey of caregiving and researching it and supporting it?
Well, actually, I came to it through my husband had a stroke when he was 46, 28 years ago. And I was told to put him into a nursing home. Mrs. Anderson, what you see is what you get. He'll never walk or talk. And I said, my kids are 11 and 16, and they're not going to visit their dad in a nursing home. He's a part of our life. This is our family. And the neurologist said, Mrs. Anderson, that's your only choice. Fortunately, because of my husband was an engineer, computer scientist, and from his position, we got referred to a physiotherapist who helped us put our lives back together again, really, our kids and our lives. So that was 1997, and in 2004, I went back and did my master's in, and then a second master's, and then my mom needed care here in Edmonton. We were living in Ottawa, so we moved back, and that's when I did some more education and took care of my mom and my husband and worked part-time. So yeah, and then I met Jasneet in 2014. She was a family doc, care of the elderly doc, doing her master's in human ecology. The same, I was doing my PhD, she was doing her master's. And it was just, this is what needs to be done. We need to change what happens with caregivers and caregiving.
Do you think that had your husband not gone through that, you would have gone a different trajectory? It's the fact that you got to see behind the curtain, say, of what's going on that really led you to go down this direction.
Everybody's heard the Rosalind Carter, everyone's going to be a caregiver in their lifetime. I think probably many caregivers, yourself included, become advocates and change agents. And the other thing is, what caregivers bring to that role is incredible transferable skills. You are not just a caregiver. You are the person that's really supporting that, the person you care for. You know them best. You've got lots of knowledge, plus, you're a doctor, a lawyer, an engineer, you've got a business person. We've got all of those transferable skills behind us. We're not a blank slate.
Do you think that certain caregivers have an easier trajectory or road, or do you think that it's all unique and there's too many independent factors contributing to say one type of caregiver is easier than another type of caregiver?
The research actually shows us that although we're unique, you can still provide person-centered care. So we are trying to provide person-centered care to the person needing care, the patient or the client. But the caregiver needs to be explicitly included as a person that's providing care to sustain care and also to maintain their own well-being. And so, starting out with a needs assessment, what do you need? What do you need to know? All of those kinds of things. Exactly. You wouldn't start to tell the patient what they need without asking them how are you doing? What are you here for today? What matters to you?
Absolutely. So can you give us an example of how your lived experience caring for your husband has shaped the way that you've approached your advocacy work, whether it's research, education, the caregiver-centered care action plan, any of these sort of things? Can you give us some examples of how lived experience has kind of said, this is what I've learned and this is what I'm trying to change for the future?
Yeah, I'm not unique. Linda Powell, her and her husband started Stars Air Ambulance. He was an emerge physician, and that was 40 years ago. And Linda is just an incredible advocate. She brings those skills that she had as a physiotherapist and as a caregiver to her mom and her husband. You're an engineer, you bring those same skills to caring for your grandmother, and now what you're doing here. Lori was a business person, did all kinds of, work in business, great speaker, a much better speaker than I am. And, the question is, how do we work in partnership with health providers, with community providers, with our families? How do we build this system in a better way?
So it's interesting you just talked about partnerships. And I know that at the the conference that happened this week here in Edmonton, that was a big discussion. How do we create partnerships? What I've heard from families, especially in the dementia space, is they're just trying to find out, how do I get supported? And there's so many silos, so many organizations that are doing great things, but they all exist independently, and the lack of, let's say, common threading between them is few and far between. So, what do you think we can do systematically to try and navigate that, so that whether you talk the Alzheimer's Society of Alberta, Northwest Territories, Alzheimer's Society of Calgary, Healthy Aging Alberta, all these organizations that do great things can all communicate and work towards one clear, cohesive vision and implementation program that supports caregivers as they need it?
Yeah, so how do we do those warm handoffs between organizations? 2 weeks ago, Dr. Parmar spoke at one of the organizations. There was about 75 people there, and I was handing out cards, and the question that was most common was, is there a difference between Alzheimer's and dementia, and what's the difference? And certainly, when Jasneet started to talk, that was the first thing that somebody asked her was, what's the difference between Alzheimer's and dementia? And so she went in to explain, the different types of dementia, and including multi-infarct dementia, which is from stroke, right? Or many strokes. So just how do we do that from the diagnosis? Because that's really what brings caregivers to this, is you suspect something is wrong. And then you go to your family doctor, and that diagnosis and that interaction takes time. And oftentimes the referrals now from a family doc to a geriatrician or neurologist or a care of the elderly doctor is sometimes a year. And even before that family has actually sought out that dementia diagnosis, they know something is wrong, and it takes them time to do that. I know as a caregiver too, when you go in for that, diagnosis, oftentimes you as a caregiver want to make sure that the person that you're caring for is shown in their best light. You want them to do well. You want what's best for them. And so when somebody says, how are they doing? And really, you don't want to say, well, there's all of these things that are going wrong. You're trying to present them, in the best possible light, because you want them to do well. So there's some real conversations about how we do that diagnosis and how we involve the caregiver in those conversations. And oftentimes the other place that I know was hard, and it didn't turn out to be hard, because my husband actually got his driver's license back, but when somebody gets their driver's license taken away, it's gone, and the caregiver has to go home, and they're the ones that have to deal with the situation. So all the way along, the person that you're dealing with really has to have some idea of what you need next, and make sure that you're handed off well. Who's doing that really well is certainly the care of the elderly docs that work in home care or primary care. We're doing a lot of work with the Calgary zone specialized geriatric team. They're spreading caregiver-centered care across Calgary. And one of the physicians tells us the story of a patient coming in, actually the caregiver coming in with her dad and saying, my dad and I are not non-compliant patients. And so what was the story? Why did that happen? Why would somebody assume you're a non-compliant patient? She said, well, you referred us to home care. And I told you at the time that home care needs to call me because my dad doesn't answer the phone. And they called 3 times, and what happens is they said we were non-compliant patients when I called them to find out why I hadn't been called. And this particular physician said, we can do things differently, we can do things better. And what they've done is they've set up systems where they're making sure that the caregiver, that handoff is done well between the one person, one healthcare provider or healthcare provider to community, so that the caregiver is really connected in all of that. Now, and that is working well. So they've got the weigh-in network in Calgary and community, they connect to them. And certainly that's a really good example of how things have changed. Now they still need some support. In Connect Care, the caregiver isn't actually identified, nor is what they do identified, or it hasn't been yet. And what happens is so next of kin is there, and power of attorney, but not the person who's doing the care and doing the work. And so that's what Calgary Geriatrics is they're asking for. That's what Dr. Parmar has been working on for 4 years, and it looks like we're going to get that. But that still doesn't mean that we have that in primary care, because they're private providers to some extent. And then oftentimes long-term care is on point-click care. So, you know, just that continuity of care, there's lots of things that we can do about it. But yes, handing off from one provider to another, and providers knowing, you know, who they need to some extent to make those warm handoffs and how they do that. So better navigation.
Which makes so much sense. I think as a caregiver, it's complicated because you especially the double duty caregiver, which you mentioned here earlier on in the discussion, but you've mentioned it previous times we've talked. This double duty caregiver idea, I think, is so hard for us to wrap our head around. It makes me wonder, how would we even systematically support? So we have these supports in place to support, say, a person who's going through Alzheimer's and the journey of that. So they get some home care, they get some other supports, but the caregiver is often left to the side of, sure, maybe they all get put on Connect Care, but now what? How do we ensure that they're taken care of? I've talked to lots of people that are caring, especially using Connect, and I asked them, how are you doing? How's your stress level? How are you feeling about this whole thing? And the kind of overwhelming sentiment is that they're feeling overwhelmed because they're having to do their regular job, whatever that is. Oftentimes they have kids, they have to work, then they have to go and oftentimes it's at least a couple times a week, if not more, be with this loved one and navigate it. So how do you reckon that we systematically address that? What have you've seen, maybe a best practice somewhere else on how to deal with that? Because it's a big problem.
Yeah, so 62% of caregivers are employed. And of those 62%, over half are doing 20 hours a week of unpaid caregiving on top of their employment. On November the 13th, we've got a panel discussion about how to support employed caregivers with some of the top people around. You know, one of the things is we talked to the human resource professionals. We did a couple of roundtables, actually 4 roundtables with human resource professionals, and they told us that even they as human resource professionals didn't know what was available for family caregivers until they were put into the role. And then they said they're kind of in a funny position because they work between the employer and the person the employee who's asking for services, who needs those support services, and who the company is oftentimes going to, or who the employer is going to, is an insurance broker who's providing those benefits. And those benefits, oftentimes it's what's most popular, what we think we need right now. So it might be Ozempic, not necessarily caregiving supports. And yet, that's, as more and more of us are caregivers, that's going to be an important piece, because you'll lose about 20% of the people that are caregivers are going to have to quit or take time off, or they're present, but they're not really there because they're answering the phone and dealing with the long-term care setting because something's wrong with mom or dad. There's all of those things that happen. So it is an employer issue that we need to start talking about. But here in Canada, we haven't had as much of a conversation as they've been having in the US, because they've got a private system where people are paying for their home care, for their long-term care. If they're not on Medicaid, it's much more costly. People tend to keep their family member at home because of how much the out-of-pocket costs are there. It was interesting. I was talking to Arlene Dickinson, the Arlene Dickinson, the dragon. It was her business manager. And, I said, caregiver, we need to support caregivers. And he said, we absolutely do, but we hear much more about caregivers in long-term care and supporting caregivers in long-term care than we do about it in the community. And I said, you're right. Caregivers in the community provide 75 to 90% of the care, but caregivers in long-term care, and this was really obvious in COVID, caregivers in long-term care provide 15 to 40% of the care, unpaid care labor. And he kind of stopped for a minute, and I thought, what have I said? And then he said, if I lost a third of my employees, I don't know what I would do. So that's the kind of things that employers are facing. It's something we need to think about. How do we make sure that those programs are available so people can work and contribute as they want to, and also to care, because that family member is depending on them.
Do you think that the caregiving experience is fundamentally different between caring for someone that's got, say, Alzheimer's or ALS or some other health issue versus caring for elders that they're reasonably good shape, but you just need to kind of keep on to make sure they're okay? Do you think that there are parallels we can draw in the experience to help us kind of navigate it, or do you think that they are independent?
Yeah, so just to actually just sort out the definition. So somebody that's caring for children that are absolutely fine and normal, that's childcare, and that's something that we need to do. But your child or my child could have been born with Down syndrome, or a genetic disorder, or as one of our neighbors' kids had a stroke at birth, so hypoxic and a stroke at birth. Normally we say those are the kids with cerebral palsy, but oftentimes it's some kind of a birth accident or hypoxia. You'll see the cerebral palsy kid with one arm up, the same as the stroke survivor. In actual fact, there are as many strokes in children under the age of 18 as there are kids with cancer. It's really important to look at the stats, but we oftentimes say those are the kids with cerebral palsy, but it actually is a brain injury or a stroke that happened at birth. So So when we're talking about caregivers, those are the people that are caring for a child, adult or older adult, for somebody that needs that care for mental or physical illness, disability, or frailty from aging. When we're talking about double duty caregivers, so 62% of caregivers are employed. Double duty caregivers are healthcare providers who are also family caregivers at home. So they're providing care in both places. Now, some people say they're triple duty caregivers if they're caring for children, their own family members, their own children as family. Catherine Ward Griffin, who actually did the double duty caregiving scale, she's Canadian, and has done a lot of research in that, says no, we've got double duty caregivers. When you're caring for your own family, you actually are like a sandwich generation caregiver, unless the child has a disability or whatever. Now, those double duty caregivers, they're an interesting lot. Those healthcare providers are an interesting lot, because oftentimes the person that needs care, the family themselves, or the healthcare provider will nominate that healthcare provider to be the caregiver because they know the system. And we have a study that we did in just after the pandemic in 2022, where many of the nurses said to us, we are not Florence Nightingale. Florence Nightingale was not married, she didn't have kids, and she wasn't a caregiver. She was a nurse. And now we're expected to do all of this caregiving, and still care at home. So within the Calgary zone, we know that they're 66.3% of their providers. We have our survey, we have 1,100 people that have filled it out so far, and 66% of those in the Calgary zone are double duty caregivers.
Do you think that systematically we need to address double duty caregivers at an increased rate versus non-double duty? So for example, if you work for formerly Alberta Health Services, knowing that a lot of the employees, based on your statistics, are going to be double duty caregivers, do you think that those sort of organizations should have specialty benefits or something to help them? Maybe it's mental health counseling, additional ones to help them navigate burnout or something to that effect?
Yeah, I think all employers, including healthcare, Alberta Health Services or Covenant Health or whoever, needs to have services for employees who are caregivers. Even physicians are double duty caregivers. So one of the things I'm talking about the roundtables, and I had 2 rural physicians say, contact me and say, I'd like to participate in these roundtables, but I'm a rural generalist, and I'm working in primary care. I work in the hospital and emerge and I'm also doing some work in long-term care because they need family docs in long-term care. And here I am caring for my mom or my dad, and I am just really stretched. So, and Verdine Bussert actually said this at an Alberta Gerontological Nurses Association meeting. She said, if you're expecting, and again, this comes back to Florence Nightingale, if you're expecting an entire shift in the hospital to come in and work, and you've just planned for just enough staff on that shift, people have kids get sick, they have husbands or wives, oftentimes they're caring for whoever they're providing unpaid care for. You're not going to have the entire shift. So we need to plan for this. We need to do it differently. If we're going to have employed people caregiving and expecting families to care, and as Dr. Janet Fast's research shows, downloading the intensity, level, load, and length of care has increased. And we need to do things differently at work and the supports we provide at home.
So what support specifically do you think that double duty caregivers or any caregivers, frankly, need?
Well, we've got that all in the strategy. So, we have, so in Canada, we have federal and provincial responsibilities. And the Canadian Centre of Caregiving Excellence has done a bang-up job of working towards a national caregiver strategy. So there's some things that the federal government needs to do for supporting caregivers. But many of the things that happen for caregivers are actually things that happen in our community, municipal responsibilities. They're also healthcare, and that mainly provision of healthcare and community care that's a provincial responsibility, and we need to see how that's organized. And fortunately, we've got an Alberta government that actually understands that. Assisted Living Alberta, is very much aware of what family caregivers are doing. The question is now, how do we do that? We're really aware of the problems. The research, I have to tell you, Dr. Donna Wilson, again, this is the Alberta government that sponsored this research. She interviewed 150 Alberta caregivers every week for 6 months. So nurses interviewed them. And what she found was that there was 11 things that caregivers needed. And then she went back and she did a scoping review to find out whether those needs were unique or different. And they'd been identified for years in the literature. So the question is how do we, what caregivers need? Absolutely. They need to have their needs assessed from their perspective. What do they need to care? What do they need to support their own well-being? Flexible services and supports. Saying to you that, we can do this for you without asking you, and this is the only service that we provide, may not work for you. If you're in a rural area, having an hour of home care as respite is not going to work when the grocery store and the bank are over an hour away. How do you drive to that service and back, and rush around the grocery store and get back home in that period of time? So services and supports need to be different. The other thing that's really important is, we really do need, we need community services. FCSS is the Family and Community Services rurally and in urban areas. The Way-In Network in Calgary that's supported by Calgary FCSS are just absolutely superb. But there's not enough of those services and supports, and they're not early enough in the trajectory. So we actually know what family caregivers need. We just need to provide it or figure out how we can provide it.
So you lead or help lead the caregiver-centered care education and champions program. Can you talk a bit about that and how what you're learning and advocating for in that is helping make a bit more institutionalized change, or help lead our healthcare system, especially in this time of transition?
Yeah. That we have a large co-design team that's been around, some of them since 2014. So there's about 150 people on that co-design team. And it's that, what do we need to do? Where does it need to be connected? How does it need to be connected? All of those pieces it's that collaboration that we need. How does Healthy Aging Alberta work with the FCSSs and 211 and 811 and the social prescribers and the primary care, and, you know, how do we, the Alzheimer's Association or the Stroke Association, all of these things, how do we work together so that caregivers are not the de facto care coordinators, system navigators, and then the care providers and the, pick up the pieces when something goes wrong. That's the piece that we need to work on. The what and how.
It's interesting you were talking about navigators there. I got an email beginning of this week from a family. So the two kids live in Alberta and the mom lives in BC. And they asked me, they said, we need help. We don't know where to start. We think that our mom has Alzheimer's, but she lives over there and we are here. And we don't know how to support the system. We don't know who to reach out to. We've reached out to ask for help. But the fact we're over here, we're relying on her to deal with it, but we can't. And I could empathize for this individual and his sister, because they're doing the best they can, but they're far away. So how would you, in that sort of experience, given all your work so far, especially the strategic action plan, suggest that those sort of situations should be handled systematically?
So that's that getting the diagnosis, that first interaction with the healthcare system as a family caregiver. So what I would do is I would call Caregivers BC. That would be my phone call in BC, and then seeing who they've got in the area or might know in the area. Really, probably somebody's going to have to go out to BC and make an appointment with the family doc and go in to do that role. And then how do you do that long distance caregiving? That's a whole other issue. And again, that's something that needs to be, that, each family and providers need to be sorted out. Dr. Janice Misaki is a neurologist that handles a lot of Parkinson's patients, and she said oftentimes she'll get a referral, and the son is in New York and he's the one that handles the finances, and we've got one daughter in Saskatchewan and they're doing this, and then the third daughter is here, and that's the one that's doing all the appointments, but it's a family that's caring. And she said, she makes sure that the referring doctor, she writes those things in the notes. Again, that's that navigation piece, right? Making sure that you're connecting back and forth. The actual person that's seeing them is connecting back and forth, making sure that people know. She said she'll often get compliments back from a family doc who says, that was really good information. I didn't know that. So that's where the electronic health record is concerned, more than just next of kin and power of attorney, actually knowing who does what. It's not going to get sorted out immediately. It's going to take some work, and it's going to take collaboration. But you saw from the groups that were participating on Tuesday, we have an incredible, from the providers, the community organizations, the Alzheimer's Association, the number of physicians that were there, all of the people that were there. We know we can do the right things. The policymakers that were there listening, taking notes. This is a real Alberta advantage. We can do this.
So you've explicitly said before, but you haven't explicitly said it here, but Alberta's caregiving co-design work is leading the rest of the country. Is there something that is happening in Alberta that's instigating this, other than all the great work that yourself and Dr. Parma are doing? Is there other things that are going there help contributing to the leading edge?
Oh, absolutely. So next week is Healthy Aging Alberta is having their summit, and across Alberta, there's connecting people and communities for living well. There's the Health Neighborhoods North. There's many primary care and community networks, NavCare, FCSSs, that are working on local community programs, connecting people and people who can do things in the community with people who can support that. And the example that I'm going to give is Drumheller. And so the nurses in the primary care network noticed that there wasn't very much in the community for older adults to do. And so they started a day program for older adults. Now, day programs are really adult day systems, they're not programs as such, because they provide respite for caregivers, and they provide socialization and network of people for the person that's going to the day program. And in that day program, because there's health providers in there, they can notice that somebody's ankles are a bit swollen and, there's some water retention here. And so maybe we need to do something, and they get an appointment at the primary care network because they're connected to that primary care network. The same thing, they've started other programs in the community. So, where there's food insecurity, how do we deal with that? They've actually started a community not-for-profit that is helping to organize these services for caregivers and older adults. We talked to the pharmacists, and they said, we're often the one that gets that person in after the transition from hospital. What do I do now? The example they gave was a fellow who has a new pen to inject his insulin, and he wasn't taking the cap off of it properly. So he, it's the pharmacist that says, show me how you're doing that, checks to make sure that it's been done. But they said, we've been trained in collaborative care, but we can do better. We could do more collaborative care because we're there. We know the caregiver in the community, especially in a small community. Gosh, I was raised in Thorhild. Daryl Coma, and I'm sure he's still there, was just a source of incredible information, and care. But what they also said was, we get one-way communication from the doctors. We don't have a two-way communication through the electronic health record. So there's some things that we can do. How do we make sure that those pharmacists are connected to some of those community organizations? I'm sure they are. How do we make sure that happens? And as you know, because I don't know anybody that's busier than you, that collaboration takes time, and it should, like caregivers, it shouldn't be a side of the desk activity.
Oh, I definitely think there's people busier than me. I definitely think I've got people. How does caregiver-centered care differ from traditional patient-centered care? And specifically, I'm talking through dementia.
Yeah, so both the person that needs, the person with dementia or the person needing care and their caregiver both need person-centered care. So it's caregiver-centered care is just person-centered care for caregivers. Now, I'll tell you, it's really funny. So when we first submitted the first paper after we'd done the caregiver-centered care competency framework, we submitted it to the Canadian Journal on Aging. And almost a year later, I finally wrote to them and said, what's happened to our paper? This is a very long time for review. And the editor wrote back to me and said, why are you using caregiver-centered care? Because there's person and family-centered care. Why do you need a new term? And we said, we wrote back and explained that caregivers were not necessarily family family doesn't necessarily provide the care. They can, but it may be it's often one family member. And that role is a unique role. You need so the caregiver, person-centered care for the caregiver is care to sustain care, so support to sustain care, and support to maintain their own well-being. So when you're talking about person-centered care for the person needing care and from the family caregiver, what they need is they need their own assessment for what the person with dementia needs, what the caregiver needs, and what they need together, really. Because it is their needs they will have some unique needs and some things that need to be addressed separately, and some that need to be addressed together.
Obviously, we're seeing the system is making, or at least is trying to make the right choices to start including caregivers into the fold. What risks exist if we don't start integrating caregivers in, especially if we're seeing dementia is supposed to go up like 280% over the next 30 years? What risks do we see if we don't get ahead of this and don't actively create systems to integrate caregivers in and continue this trajectory?
You're going to see more and more burned out caregivers is what you're going to see. Employers, what people leaving employment or being able to do that. About half of caregivers, because of the, caregivers in Canada, the out-of-pocket costs are anywhere between, on average, of $300 to $1,000 a month. That was back in 2018. I would say they're higher now. So how do we organize this care system differently than to support the families that we have now? My dad was one of 11 kids. My mother was one of 9. There are 6 kids in my family. I have 2. And I know many people that only have 1 and many Canadians are choosing not to have any children. So who's going to, if we're going to move that care to the community, we're trying to have less institutionalization, and we need long-term care. When care becomes more than one family caregiver or one whole family can do, you need a team to care. And it doesn't become, it's just not cost effective to have, you just can't provide that intensive care effectively to one person in a family home, maybe that's got 2 stories and stairs all over the place. So we have to there's lots of things that we need to do, but it's a matter of changing from that medical focused system, which was really transactional, based on you come see the doctor, we'll fix that, or we're going to send you home. And very little hospital care. That that was the model previously, and then people would go into long-term care. Oftentimes, when I was growing up, the parking spots at the long-term care home were for the farmers that were going to drive home and assist their kids with the combining and driving the tractor in the spring. The average age of men when I was growing up was 70. It's now 85. So, how do we organize this whole system differently to account for different lives?
What's interesting is I had a conversation with someone not too long ago, and they were arguing that the system, what we need to do is just increase more institutionalized beds. There's not enough beds out there. And I mean, statistically, there's 22,000 people with dementia in Edmonton, the capital region, 1,132 beds. So we're having, about 21,000 folks living at home with their families or some combination of that. Their argument was, all we need is more institutionalized beds. Let's not worry about keeping them at home. That'll decrease the burnout. What would you say in response to that? As you know me, I had a lively debate on the issue, but what would you say?
Yeah, I don't think we can build our way out of this issue. And I'm talking about 2018 dollars here because I haven't looked at it recently. So in 2018 dollars, the spending for just the care of a person in long-term care, because I think the person in long-term care pays for board and room, but the care cost $75,000 in 2018 dollars. And to build that bed, not to maintain it, just to build it, was about 495,000, I think. So if you start to think of what it would cost to institutionalize, that number of people just with Alzheimer's, not with only with Parkinson's, stroke, all of the other things that are happening. And also the other piece that people don't understand is many times when there's those drug overdoses, they're often those young people are often brain damaged and end up in long-term care. They're to some extent their stay in long-term care is much longer. So how is that can we afford that? And then the other piece of that is that where Canadians want to live. Most Canadians, 98% of them, want to live in their community homes, in their communities for as long as possible. So, certainly the incentive should be to reorganize the system to fit our lives now.
For me, that's so important because for us, our slogan is restoring the personhood independence of those living with dementia. Instead of fitting a person into a box, let's fit the box to mold to a person. I think that's really what this caregiver action plan and a lot of this forward-looking stuff is. How do we adapt what we have to meet the diverse needs of those who are being impacted by?
Yeah, even acute care and emergency is really, really important. You want them there at the ready. We don't want people spending time in alternative level of care beds if we don't have to do that. And I think we as Albertans should probably be thinking about, how we organize our lives and our communities and our homes so that they are accessible, that we can do things, that we can live in them as long as possible, or move to accommodation that's much easier. We had a large 4-bedroom house in Ottawa, and it actually worked when John first had the stroke. We were able to do lots of things, and there were some times where it was pretty unsafe, probably coming down those 14 steps down to the main floor from our bedroom. But there's lots of things that we've moved to a condo. That certainly would work much better for people to actually think about where they want to live, closer to kids, maybe, in communities where they can walk to the grocery store. The other thing is, people oftentimes don't even think about, how much it costs them for insurance for their car when they could take an Uber. And they wouldn't have to worry, we worry about losing our driver's licenses. But Uber works quite well, thank you very much, if we know how to organize it, or Drive Happiness, or some of the, oftentimes the bus can work really well. So how do we do those kinds of things? How do we organize this better, build our communities so that they're more accessible for people with, kids with strollers, as well as people with wheelchairs or scooters?
And since you're addressing community, the framework that was developed really focuses, or I guess the strategic action framework, just so people can search it, really emphasizes community-based assets. What kind of local strengths or partnerships can help build dementia-friendly and caregiver-safe communities?
Yeah, I think social determinants of well-being. The social determinants of health were developed in Canada, but they really should have said social determinants of well-being. And really, we need to start looking at communities and interdependence of people in communities rather than independence. We never are really independent. We're always interdependent, you know, husbands, wives, neighbors, friends, you know, all of those things, all the people that we depend on. And yeah, you know, the things that Healthy Aging Alberta is doing, the Connecting People for Living Well, the FCSSs, I cannot say enough about and how much we heard in our roundtables. You know, one of the fellows, Lucas, in several of the interviews with the care of the elderly doctors, the family doctors, the geriatric medicine specialists, primary care, all of them mentioned Lucas. It was like, yeah, we have him on speed dial because he's at the FCSS. He's the navigator, knows where programs are, and if he doesn't know, he finds out.
That's such a valuable asset, though, to have in your back pocket, let's say, because the system inherently is so complicated.
Yeah, and you know, so oftentimes, you know, where do you refer a caregiver who's having financial difficulty? So somebody who's having difficulty filling out their income taxes and hasn't done it for a bit. You know, either the person they're caring for because they've had dementia or Parkinson's or stroke or whatever. And so, you know, that social frailty that happens because of that health condition often, you know, people start to lose their networks and their friends, and they don't complete their, you know, we heard from one of the organizations in Calgary, this particular fellow was in hospital for a while and he couldn't remember where his bank was. And in this case, the social workers from Korea actually, you know, found his relatives, found where his bank was. You know, they go in. This is a really good example of that connection with community. So, you know, for people that have been in the hospital for a period of time, those long stay patients, they actually go into the hospital 2 days before the patient is discharged, meet them, they enroll the person and the caregiver, if they've got one, into their social prescribing program. And then they start to sort out the things that they need to get them connected again back into that community. So they're working with the physicians in acute care. They're working with the physicians and teams in Calgary geriatrics and the care of the elderly doctors in primary care and primary care physicians, and with community, the Way In Network in Calgary. Just a brilliant model. That's the model that we can use elsewhere. And it is happening.
Is there any countries or regions away from us that we can look to and say, you know what, that is what a great caregiver safe environment would be? So when we look at, for an example, dementia, institutionalized dementia care, the Hogevik is kind of the gold standard in the Netherlands for this is what we look to for freedom. Japan is another really good example where the individuals with dementia live in this community. There's not walls. They can move around. The community will then direct them, guide them, send them back where they have to go, and ensure that they're safe. It's kind of a communal support relationship. Is there any sort of places, regions, nations that we can look to in Alberta and say that is the gold star that we want to get to?
Yeah, I honestly think that we can have a made in Alberta model. You know, so for example, you were at Still Me in Calgary, where we looked at the Sherbrooke community in Saskatchewan. There it isn't locked dementia ward. If you lock people in, they try and get out. But there's lots of things that we can do, and we build this system, build this environment, so we support people. We understand why they're wandering and what the issues are, and how we can sort that out, and why they're exhibiting those responsive behaviors. But that takes time and work and a particular staff. In Denmark, when I was in Denmark about 4 years ago, they haven't built nursing homes in Denmark for probably 10 years or more than 10 years. But what they do have is really essentially their small apartments, but they have staff that go in. So it really is just a smaller homes model, of long-term care here. What would work here? We've got some small homes models that work in Alberta. The question is how do we do that? How do we set up our home care system for what's here? Australia has some really good models, as does New Zealand. There's some community health models, but Grand Prairie is actually doing that right at the moment. What they're doing is their primary care, their hospital, they've got physicians that are being, the rural medicine program from the University of Alberta. They've got a similar program in Calgary where they're training rural generalists right from the get-go. So we should absolutely look to other countries, but we should actually look as well at what would work here, because every little local community has assets. So that's Cormac Russell's asset-based community development model. That's really what Drumheller is doing. That's what Cold Lake is doing. And certainly there's, the community ecosystem model that will be displayed that we'll talk about it at the Healthy Aging Summit next week. Is part of, actually it's the week after next. That's part of what we can do, is already happening in Alberta. And then absolutely the Dehoviks, like the Langley Dementia Village, there's things that we can do with those smaller homes models, but a made in Alberta model.
It's really inspirational to hear that there are so many great success stories of this working. You've talked about Drumheller and some of the good things happening down there. You've talked about Grand Prairie. So it's really good to hear these examples, especially for Alberta caregivers. And it really is a testament to the idea that, we are on that leading edge, and you are strongly involved in leading us going down that road. So I just thank you for your work in that. I just have one kind of closing question. So you've worked in education, research, advocacy. When you think about the future for caregiving of dementia in Alberta, what gives you hope?
Oh, Arlene Hoon said it best on Tuesday. We're small, but we're mighty. I think if we can, radical collaboration that we're doing here in Alberta, looking at what works, and then building on that and making sure that we're doing what works in all those other communities. How do we transfer those good models of care elsewhere? And the other thing is explicitly making caregivers part of the care team is critical.
I agree with you there. I mean, my grandfather is 90 something, and he's as spry as a 90-something-year-old guy is. That he was telling me a couple of days ago, we were watching curling, and he goes, "It's only been probably 4 or 5 years since I curled last." I'm like, "You're like 95."
Yeah,
it's been pretty good. Yeah. And we still, to this day, we still have a list of this is who the other people of the care team are, and I think that's such a valuable thing for at least my family. This is who the care team members are. We're all aware. We understand who each other is. We understand how to communicate with each other. those are such important pieces to support that future caregiving direction.
Yeah, well, my mom lived to be 101 and a half in her own home, passed away in her own bed, and had a shower every day because I loved her showers until about the last 3 days before she passed away.
Wow, such a strong woman then to be able to do that and hold on to 101. That
She
says
was
a
a
lot.
she was a teacher in Northern Alberta, taught in one-room schoolhouses. My mom and dad homesteaded. And yeah, many of the things, the collaborative things that happened then are still things that are here we can still build on.
Always moving, hopefully in the positive direction, just building on what we've learned in the past, and still learning on what the great things that were done before us, right? But thank you so much for joining us, Dr. Anderson. It's been an honor to have you on this episode of the Dementia Collective. It's been wonderful to hear you continue the talks that I've heard recently quite a bit and all the events, because folks don't know, you're always doing events and always talking and collaborating, and it's amazing to hear what you're doing. You're doing a wonderful job supporting caregivers and ensuring that older adults are cared for, with dignity and compassion. For our audience, if something in today's conversation stuck out with you, please make sure to follow the Dementia Collective on your favorite podcast app and share it with someone who you think might need to hear it. If you're walking the dementia journey yourself, we see you. You're not alone. Whether you're just starting out or deep in the day-to-day grind, we're here to help. Visit us at BlueBell to learn more or reach out directly. Until next time, you are seen, you are strong, and you are doing something that matters more than you know. I'll see you next time.